This is a case of laparoscopic Nissen fundoplication in type 4 paraesophageal hernia. You can appreciate very large hiatal defect. This is the port position. I made regular 5 ports, 10 mm camera, all 4 other ports are 5 mm, and this is the team setup. And sometimes I put one more port extra on the right lateral side to retract the lesser curvature of stomach. So I take the camera inside. This is the 30° 10 mm scope, and you can appreciate there is a lot of the content of abdominal content inside the chest cavity. Coming to the operative steps, we have to do the reduction of content, dissection of and excision of sac. That is the main importance in type 4. Then mobilization of the esophagus, crural approximation, and fundoplication. So now I try to reduce the content. These are all the omentum. Almost the whole omentum is inside. We have to still I am not seeing the stomach. A lot of omentum is coming out. Now we can appreciate the stomach, that is the antrum of the stomach, no, it is coming inside, coming out. So that is the antrum of the stomach. So I am trying to take the other part of the stomach. So most of the time it will be like a mal rotation will be there. In this case there is no mal rotation. So I am trying to the other side, that I am trying to take out the omentum. So this time suddenly the colon has come out. No, once see that is a colon is coming out. So it is a type 4 colon omentum, and the stomach, entire stomach is inside the thoracic cavity. Patient is more symptomatic. He is not able to take food, and even for one small quantity of food, he took around more than an hour. So now I am trying to hold the stomach. Still the entire stomach is inside. We have to use atraumatic bowel grasper. It should not injure any organ, and so the lesser curvature of stomach is, I am trying to take it out. It is not possible to take out the entire stomach out and then you can start the dissection, because long standing, it will be deep inside. Last case, you have shown it is a large hiatus, but it is not deep. This case you can see, it is so deep inside. So it is not. It's a little bit difficult, to do the surgery, and so it is a very large hiatal defect with the type 4 paraesophageal hernia. And as usual, I started with the gastrohepatic omental division. I didn't change any steps, even though it is a large hiatus hernia. And immediately you can see the caudate lobe and the right crest of the diaphragm. There is a right limb of right crest of diaphragm. See, my aim for this patient, first surgery is the reduction of the sac. I have reduction of the content and then excision of the sac. So I am trying for a sac excision. That is the right crest only. I am separating the sac from the crest. So you can appreciate here I am holding the sac, not the stomach. So once you take out the entire sac, then most of the stomach part will come out. The only thing you have to mobilize the esophagus from the mediastinum. So the type 4 and some kind of type 3 paraesophageal hernia, the sac excision is the key of success of your surgery. Without sac excision, if you try to mobilize, you may injure the organ of stomach or the esophagus, and the chance of recurrence is high. So we have to take out the sacs. Now that is the lesser curvature of the stomach. That fat is the lesser curvature of the stomach. So I am carefully separating it. No need to worry about the vagus because it is so inside stomach content. Almost I am working with the lesser curvature level. So again I am shifted my instrument to proximal, so that it will give a traction is good, so I can able to find out the plane. Any tubular structure is there, you just confirm and then divide. Otherwise, you can mobilize the sac like this. It's you have to take it all around. No, I started from right side, then I'm going anteriorly, then I go posterior, and then I go for a left side. Still, that is stomach only. It is not a esophagus. So, what the structure you are seeing inside the mediastinum is the stomach. So, you can see I am not seeing esophagus till now. The entire stomach is still is inside. So, very large cavity on the left side. See, again I started the division of the sac. So, now it's kind of anterior dissection I am doing. I am taking out from the anterocruciate ligament, and again I am coming out of the coming on the left limb of the right crest. You are in the right plane, the gas will help you for the dissection. It is very considered as a very prime important steps for paraesophageal hernia is the dissection and excision of the sac. So, now almost the camera sees inside the mediastinum, you can see the lung. So, that is some vessel, it is maybe branch of vagus. It is I'm working close to the sac, I am not working on the esophagus. And such a big cavity you can appreciate here. The sac is coming out means the stomach is coming out, it will come out. It's again it's maybe done in some of the conference or meeting. So, you can see the external views. The normally we don't record the external view, it is in the PIP. It is done long back, it is around 2017 or 18 I have done this case, almost around 5 years before, 5 to 6 years before. Now, you can see I am coming on the left side, anteriorly complete, I am coming on the left side. So, now that is the fundus of the stomach is coming out. Now, one sac is coming out, the fundus has come out. So, that is the sac, this is the fundus of the stomach. So, I am carefully separating the sac from the fundus of the stomach. When you are going medially, now you have to careful about the vagus now. And here it is well away from the, because it is on the stomach I am operating. So, any thick structure or a tubular structure you have to check all around and then divide. So, now you can appreciate the left limb of the right crest is seen nicely. So, almost the sac has come out from the left side. Again I am making the content thin, and then I am dividing the sac. So far I am not concentrating on esophageal or stomach mobilization, I am concentrating only on the dissection of sac from the mediastinum. So, almost it has dissected, and only the small portion on the lesser curvature side it is adherent. So, again I am checking all around. You can appreciate how much sac is I excised. So, it is a big sac, big one. Even collapse sac, after excision it will become collapse, even the collapse is size is big. Always confirm before dividing any structure. If it is a thick one, make it thin and then see any tubular structure is there or not, then divide. So, I am making thin and then does not look any tubular structure. See, now you can see I am confirming it and then I am taking down. So, the complete sac is excised. You can appreciate I just keep the sac like this. It is a collapsed sac, the size is this much. So, I keep the sac away. I started, that is the colon. So, that is the stomach. So, again still I am not seeing the OG junction and it is inside the mediastinum. So, I started dissection of the lesser curvature attachment to the right crest of diaphragm. And even the left gastric artery will be inside the mediastinum. Almost antrum pylorus is inside. So, we have to preserve this lesser curvature arch and we should not divide that and make sure that there is no tubular structure, then divide. So, now I am slowly going inside the mediastinum, that is the stomach. You can appreciate, that is the stomach, and I could able to see the esophagus inside the mediastinum. And everybody thinks about the short esophagus, and actually that is the myth most of the time. So, that is the esophagus. You can see the entire esophagus is inside the mediastinum. I have to, it's required around 3 to 5 centimeter into abdominal esophagus is required for fundoplication. And so, it doesn't, it look like a short esophagus. So, after mobilization, it will come out. And it is a myth, and very rarely we required Colles gastroplasty, for we see a short esophagus. Otherwise, most of the time we can able to dissect the mediastinal dissection and then sorry, we do the mediastinal dissection, we can bring out the esophagus down to the abdomen. So, now I made a circular retroesophageal window. I am tying the tape around the OG junction. Now, I could able to identify the OG junction. See, now you can see I am tying the tape around the OG junction. This is a cotton tape. So, that hereafter I can hold the tape, I can give a good traction on the esophagus. See, there is a cotton tape at the OG junction. So, that with the tape I can give a traction on the esophagus, I can do the mediastinal dissection. So, now only we are able to, I can able to see the esophagus. So, we have to see the pleura and all other structure, and particularly the vagus nerve we have to see. We should not injure the vagus nerve. Do not expect vagus nerve close to the esophagus in case of large hiatus hernia. It will be most of the time it will be away from the esophagus. In a normal anatomy, it will be close to the esophagus, around close or 1 centimeter distance from the esophagus. Otherwise, it will be away. So, these are all the fibers from the right vagus, sorry, left side vagus. So, this fibers is there, no, it is because the left side vagus is giving a branch to the stomach that I divided. So, it is continuity is maintaining is, and again I am giving traction on this side. Still I have not identified the right vagus, post vagus. So, again the sac portion is coming out. So, that is the left cruciate ligament, that is the both limb of right crest is joining, that is the inferior phrenic vessel. You can appreciate the left limb of right crest. So, I am trying to make a window. So, now that is again I am doing a mediastinal dissection. Lot of loose areolar tissue will be there. Even the pleural injury is acceptable than the vagus injury. So, look for vagus carefully, and as I told you before, it will be away from the esophagus, will not be close to the esophagus. So, again I am going almost I dissected, mediastinal dissection is done. So, I am started doing a fundal mobilization. So, I enter the lesser sac and go close to the stomach, and now I catch the posterior wall of the stomach and divide all the short gastric. So, that will be the short gastric. So, a lot of fat on the stomach side because of the long standing stomach is inside. So, it is that side fundal mobilization is over. I am coming on the right side and trying to take out the fundus on this side. Some of the facial attachment. You can see my harmonic tip, just below the tip is the inferior phrenic vessel. So, that is the vagus, post vagus now. So, I am lifted the vagus, I am dividing all the structure. So, that is the vagus now. And there should not be any mediastinal attachment to the esophagus. So, we have to follow all the principles of laparoscopic Nissen. Even though it is a difficult and large hiatus, we should not miss any principle. Actually, it's a mediastinal dissection is easier, it's not difficult, but only thing you should not divide any tubular structure. You have to dissect, confirm, and then divide. So now we can appreciate the aorta, thoracic aorta, and the posterior dissection is complete, and so that is the inferior phrenic vessel. So that is the left limb of right crus of diaphragm, and you can see it is a bulky and healthy diaphragm. Almost dissection is completed. Even the window is created nicely. These are all the posterior attachment of the stomach. So now I started closure of the crus. That is a crural approximation. So that is the left limb of right crus of diaphragm. You can see I am taking a very deep. I keep my left hand instrument to prevent the aortic injury. You can see how much depth, entire thickness I have taken. So again I am taking on the right limb of the right crus of diaphragm. IVC is very close by, we have to be careful. Same suture, 1-0 polyamide suture, or otherwise called nylon suture. I'm doing a Sabo C loop technique. I'm making a double half knot with a C loop. This is one of the strongest suture. Now I'm making another knot. One of the strongest suture compared with the polypropylene. You can see the entire peritoneal covering of the crust is being preserved. So that is another key factor for a good crural approximation. I am taking a full thickness suture. I am very happy that I could able to take the full thickness suture, and it is crust is not under tension. It is not under tension. I can able to approximate. So why I am telling this point? If it is a good developed crust is there, no need for mesh. So if it is a tension crural approximation, and then any limb of the crust is right crust is thinner, then we have to think of mesplasty to strengthen the crura. This is crura is so well formed, and without tension I can able to approximate, and I am also taking a good thick of the crura. So I think no, I am not going to keep the mesh for this patient. Again I am continuing this crural stitch, and if it is a large this type of paraesophageal hernias, it required multiple crural stitch. If you keep on going from posteriorly, doing placing a suture on posteriorly, it will produce tenting of the esophagus, it will lift the esophagus. So we have to do alternatively posterior and anterior, so that the esophagus will be lie in a straight line. So I have done around 5 suture, and I am not making this. I am just placing it, releasing the esophagus. So this is the normal lie of the esophagus. The esophagus will lie normally like this. If you keep on doing posterior, it may produce elevation of the esophagus at the level of hiatus, that is called tenting of esophagus. So it will produce dysphagia. So now I am taking a suture of the anterior cruciate ligament. Again, anterior cruciate ligament looks stronger. It is not a very thin fascia like, and many cases I used to do like this. If it is a thin anterior cruciate ligament, then hiatus to be strengthened with the mesh. It is thick, you can see I'm holding the cruciate ligament, I'm taking a good thickness now. It's a very well formed anterior cruciate ligament, and this side also you can see you can appreciate I'm taking a good thickness of the crest, right crest. So now I'm approximating it. So it is well formed crest on both above and below. So I think it is no need for mesh in this patient. As much as possible, we are avoiding the mesh. So now it is a, you can see I preserve this inferior phrenic vessel, and adequate hiatus is done, and the empty esophagus is occupying the hiatus. So I am planned for fundal wrap now. No mesh is required this patient. So that I keep the fundus. I am taking the posterior fundus on this side. So I am doing a suicide maneuver. It's a very tension free, it is there. So when you are doing a suicide, the esophagus rotation is not there. So I am taking an anterior wall of the fundus. This patient had a normal motility, esophageal motility in a manometry. So I am doing a Nissen fundoplication, 360-degree Nissen fundoplication. I am taking stitch on the anterior wall of the fundus. This is stitch on the esophagus. Again stitch on the posterior wall of the fundus. You can appreciate that is the posterior wall of fundus. So I reverse the needle. You can see I reverse the needle. Then I am taking post wall to anterior wall. It is a kind of mattress suture. So I am taking the anterior wall now. So again, so starting point, same point I have reached. So it is kind of U stitch. So I'm going to approximate the stitch now. So since I take the esophagus wall, so the wrap will not move up and down, it will be in the same place. And you can appreciate the below the wrap OG junction is there. I'm almost 1 to 2 centimeter above the OG junction, I'm making a wrap. And then above the wrap also you could see good length of intra-abdominal esophagus. Now this is the second stitch, wrap to wrap stitch. This time I don't include the esophagus. This is wrap to wrap. Wrap to wrap means anterior wall of wrap to posterior wall of wrap. Sorry, posterior wall of fundus, anterior wall of fundus to the posterior wall of fundus. This is the two suture I used to do for entire Nissen, but this case I made another stitch on the fundus to fundus, that is anterior fundus to the posterior wall of fundus. So, good length of intraabdominal esophagus is there, 360-degree Nissen fundoplication is done, and the fundal wrap to the fixed to the crura, that is a important stitch. That is a transmigration prevention stitch. I am also taking the stitch in this patient. So, that is the post wall of fundus. Again, I am taking a good thickness, and I am taking a crest, right crest of diaphragm. So, good thickness of the right crest I have taken. You can see now in the external view, I am operating very comfortably. My shoulder strain is not there, my shoulder is not elevated. So, you have to place the port accordingly. Even 3 hours surgery, you won't have any shoulder strain. So, now you can see I am taking a anterior fundus, that is a wrap to the left limb of the right crest. So, this is the stitch on the fundal wrap to the left limb of right crest. You can see I am taking the full thickness of the left limb of right crest. It will give additional support, it will keep the wrap in place. So, wrap both the wrap anterior surface of the fundus wrap and then posterior surface of fundus wrap is fixed to the crest. So, now the cotton tape is being divided. So, you can see the sac, I made trocar, big trocar 11 mm or 12 mm, I take the entire sac out. See, you can see in the external view the sac has come out. You can see just I am keeping the sac in my hand. Now you can see the size, it is a very big sac. Just to show the size of the sac, I am keeping like this. So, it is a complete sac is excised. If it is a stitch means it will be stretchable, but I did not stretch. You can see it is covering the hand like this. You see it is a big sac, no. So, again it is keep it on the flask, so see the size. So, it is a completion of laparoscopic Nissen fundoplication in a type 4 paraesophageal hernia. So, all the step is being followed and it's complete the surgery. Thank you.